Hello, my name is Dr. Jill Einstein, and I'm the Senior Director of Physician Engagement for MAVEN Project. Thank you all for joining us today and our friends at Health Point Midway in Washington for hosting today's session, which will be on postmenopausal osteoporosis drug treatment guidelines and update with Dr. Craig Sadur. Dr. Sadur was an assistant professor of medicine at the University of Colorado Health Sciences Center and chief of the endocrine unit at Denver General Hospital. Then, after 9 years of private practice in endocrinology, he joined Kaiser Permanente, Northern California, where he practiced clinical endocrinology for over 24 years and received the Career of Caring Award for exemplary physicians. It's wonderful to have you here today, Dr. Sadur, and I'll turn it over to you.
Okay. All right. Thank you so much, Dr. Einstein. And let me get this up and running. Okay, whoops. All right. So welcome to everyone. Good afternoon. And today we were going to go over the postmenopausal osteoporosis drug treatment guidelines, which came out not too long ago, and the updates that have been in the field since then. And the information comes from the Endocrine Society, where the guidelines were and where most of the research funnels through, the largest group of endocrinologists, not just in this country, but in the world. In addition to the Bone Health and Osteoporosis Foundation, which has the little fracture logo right there. So the goals for today were to include non-pharmacological treatment for postmenopausal osteoporosis. So even though it's pharmacologic treatment, for me, it's helpful to remember that there's other things that we can do that are very practical for helping our patients. And to use risk stratification to manage the treatment, drug options, and the risk assessment, which really helps individualized therapy. Medication duration is a big question. We'll go over that and the subsequent options, and consider alternative medications if the drugs of choice for whatever reason are not appropriate. So with that, defining postmenopausal osteoporosis, and it's defined as characterized by low bone mass, microarchitectural disruption, skeletal fragility, resulting in decreased bone strength, and the bottom line is increased risk of fracture. And here you get an idea on this photo that you get these porous bones with relatively low trabecular volume, and you can just picture the risk that they would have for fracture. So fragility fractures, defined by occurring from a low or minimal trauma, and the classic one is falling from a standing height or less. So most people have good bones, strong bones, when they fall from a height, don't break bones, but for those who have low bone mass, fracture is certainly a risk. And the most common sites are the spine vertebral compression fractures, hip and wrist, but you also see it in the humerus, the ribs, and pelvis. Now, there are classical risk factors for osteoporosis, and most osteoporotic postmenopausal women have their bone loss related to their estrogen deficiency, which occurs relatively precipitously with menopause, where estrogen levels go down significantly, and or age. So we see it in men in terms of osteoporosis later in life, but we're focusing on women in postmenopausal today. And the classic risk factors are low body weight, past fracture, a parental hip fracture, current tobacco use, glucocorticoid use, rheumatoid arthritis, one of a variety of secondary osteoporotic etiologies, significant alcohol use, and low bone mineral density. But if you look at the risk factors, those were the classical, but there's a lot of other ones. So if you've had a patient with a past fracture, and again, anything except toes, fingers, nose, skull, which are not included, anything else is game. And if you look beyond the parent's hip fracture, just any kind of fracture, but especially hip fractures. If you've had a patient who's lost more than 1.5 inches in height, various inflammatory disease like inflammatory bowel, hyperthyroidism, and along with that would be an over replacement of therapy for years where you have a suppressed TSH, leads to increased bone loss. Hyperparathyroidism, which could be primary or secondary. Diabetes, types 1 or 2. Glucocorticoid excess, which could be endogenous or exogenous from a variety of sources. Hypogonadal state. So we've already talked about postmenopausal, but for men, low testosterone is a concern with the potential risk for significant bone loss. Various GI diseases, malabsorption, or someone with short bowel, or someone who's had significant resection. Cancer, particularly the prostate and breast cancers, various medication for patients with prostate, CA, androgen deprivation therapy, the aromatase inhibitors, glucocorticoids, like we mentioned, protein pump inhibitors, the anticonvulsants, SSRIs, thiazolidinediones for diabetes, and then lifestyle factors, smoking, prone to falling, excessive alcohol intake, and immobility. So you can imagine there's a lot of people who would fit into somewhere on this list. Let's go to cases. We've got a 70-year-old Black female who recently had a hip fracture. So 70 years, she's older, which means that there's the inevitable bone loss. Now, with ethnic groups, Black is relatively low in terms of losing bone. In other words, in Black population, the bone loss is not as severe if you look at a population study as, let's say, East Asians or Latinos. But of course, Black people do get fractures. Female, again, she's postmenopausal. And recent hip fracture, really the dreaded complication where hip fractures can be so devastating. So you've got her as your patient. And think in your mind, what tests might you want to order? And what tests beyond blood tests would you want to check? And what do you advise her? And do you prescribe medication? And if so, what medication? So with this, the labs that are reasonable to look at would be calcium. You know, you're wondering about hyperparathyroidism or hypercalcemia, a variety of causes. Phosphorus, you have patients with hypophosphatemia. They can get various neuromuscular diseases. Albumin, which helps assess liver, but also it helps you assess whether or not the serum calcium is truly abnormal. Thyroid stimulating hormone, a good screen for thyroid disorder. Total protein. You want to look at renal function, liver enzymes, alkaline phosphatase, serum electrolytes. So easy, routine labs that are accessible. Complete blood count, myeloma patients, among others, are at increased risk for osteoporosis. And looking at vitamin D stores. So this is the 25-hydroxy vitamin D, which is the best single test to get an idea if the stores are adequate or if the patient is vitamin D deficient. Calcium is recommended, so you want to supplement with calcium. So it's recommended 1,200 milligrams a day from all sources. So occasionally you see a patient who really is quite a dairy ingester. And for that patient, she may not need supplemental calcium, but for almost all patients, they do. You often need at least 500 milligrams a day and commonly 500 milligrams twice daily. And you want to split it up so you get better absorption. And the studies have shown that as patients age, there tends to be lower and lower amount of calcium in their diet. And then vitamin D, 800 international units a day is recommended for across the board, but some patients need more. And the Institute of Medicine says for most patients, do not go over 4,000 international units a day because then you start to be concerned about the possibility of vitamin D toxicity. Now, there are some patients because of other conditions need more supplement for vitamin D, but we're talking about the most common scenario. Smoking cessation. As we've seen, there's so many reasons to quit smoking, but for whatever purpose, a patient who realizes that smoking adds to her bone loss, that may be enough to stimulate her to stop smoking and avoiding excessive alcohol. So there are non-skeletal risk factors in terms of fracture and osteoporotic sequelae, poor eyesight. And so if that's the case for your patient, refer her to the eye clinic. Poor hearing. If that's the case, have her evaluated by audiology if she needs hearing aids. Poor balance. Again, we're concerned about the possibility of falling, and that's a big factor in fracture. And there is balance training, and physical therapy can evaluate a patient for gait assessment. Muscle weakness. Calcium, vitamin D supplementation have been shown to help for patients who are deficient, weight-bearing exercise, resistance training. So you want to think about non-skeletal risk factors because they're so pragmatic in terms of what we can do to help our patient lower the risk of fracture. So with this patient, she does meet criteria for prescribing medication. And Clifford Rosen of Tufts University, to quote him, has shown in studies that you can safely give bisphosphonates within the first week after hip fracture and consider zoledronic single infusion. That's the intravenous form. So she fractured her hip. We've got her in the hospital, and this is a perfect time to start therapy. It used to be the thinking now, well, you should wait on bisphosphonate anti-resorptive therapy because they're healing, but it turns out these patients do well with treatment. So it could be oral, it could be intravenous, but it'd be good to get them started soon. Now, while people are on treatment, you want to monitor. And there's the bone mineral density or the DEXA scan of the spine and hip, and that assesses the treatment response. And if for whatever reason the patient doesn't have access to a bone mineral density, alternatively, you could check the serum C-terminal cross-linking telopeptide, shortened to C-telopeptide, for the anti-resorptive treatment like a bisphosphonate, or go to the P1NP if you have a patient on an anabolic treatment, and we'll go over those treatments in future slides. So here's the bone mineral density. The DEXA scan takes just a few minutes. It's non-invasive. You could sleep through it, except it's so quick, patients usually don't have time to fall asleep. And here is the questionnaire that is used to fill out. It's country dependent. So if a patient is an ethnic group, let's say Brazilian, there is a specific Brazilian subset for this tool. And the questionnaire, you put in the age, you put in the gender, the weight, the height. They even have conversion if you go from kilograms to pounds and centimeters to inches, and simple questions. Whether there's previous fracture, parent fracture to hip, the smoking, the glucocorticoids, the rheumatoid arthritis, some sort of secondary osteoporosis, and alcohol 3 or more units a day, and we'll go over. And then the femoral neck. So you put in the bone mineral density of the femoral neck, and you need to know the manufacturer of the machine, which should be on the printout. And then you get your calculation. So alcohol does lots of bad things, as we all know. It affects multiple organs, one of which is bone. It impairs fracture repair, reduces bone density. We see more fractures in people who are high intake for alcohol. So the alcoholic units, I don't know about you, but I needed to look up what a true alcohol unit was. And to fill out the form, alcohol by volume is the amount of pure alcohol as a percentage of total liquid volume. And it's listed as volume or alcohol volume on the drink. So because a drink there could be, let's say, 12% alcohol by volume, should say right on the bottle. And you can calculate the units by multiplying the total volume in milliliters by the alcohol by volume as a percent, and then dividing by 1,000. So you get the alcohol by volume, the milliliters, then divide by 1,000, and that gives you your units of alcohol. An example, a pint, 568 milliliters of strong lager, 5.2% alcohol by volume. You multiply and then divide by 1,000, you have 2.95 units, which was just under the 3 units that was listed in the bone mineral density bimodal. It's high or low. So that's how I was able to find out, oh, that's how you calculate alcohol units. So again, with the tool, you got your questionnaire. Here's a patient who's young, 58, female, her weight, 70 kilos, 168 centimeters. And her screen was negative, except she's a current smoker, which adds to her risk. And then you do the calculation, and you get what is called the Frax number. And it's an estimate, a calculation of what would be the likelihood in the next 10 years for this patient to fracture. And a major osteoporotic fracture would be something like vertebral body or radius. And so her risk is 5.7%. And hip fracture, which is separated from the major osteoporotic fracture, is 0.9%. These numbers are relatively low, but it gives you an idea, where does she fit into the population risk management? Specialty labs rarely needed. 24-hour urine for calcium. If you had a patient who, let's say, repeated kidney stones, and if you happen to know there was calcium stone, you wonder this patient could be hypercalciuric, so that may be one. If you have hypercalcemia, checking a parathyroid hormone level, if there's a question of myeloma, SPEP, but usually you don't need the specialty labs, but they are there. Okay, now with the guidelines, risk stratification has been very helpful because it tells us what direction we go down the pathway. And so the first category is low fracture risk. And as you can imagine, this is what you want your patient to be. So this is a patient who's had no past hip or spine fractures. And the bone mineral density T-score is measured. Now, T-score, just to let you know, is a measurement comparing this patient to this mythical 30-year-old woman. So when girls go through childhood and adolescence, their bone density increases. And when they reach adulthood, as a woman, their maximum bone density is about age 30. And after that is the inevitable loss. So we're looking at our 70-year-old patient who's in the case number 1. It's no surprise if her T-score is negative compared to this 30-year-old because of the effects of age. But you look at the T-score of the hip and you look at the T-score of the spine. And if they're both above or better than negative 1.0, we're talking about standard deviation from average, and the 10-year calculated hip fracture risk is less than 3%, and the major osteoporotic fracture risk is less than 20%. That's a great profile. No fractures, good bone density. This patient does not meet the criteria for pharmacologic therapy. And it's recommended to reassess her fracture risk in 2 to 4 years, because hopefully she'll stay in the low fracture risk, but she might not. Now, we're moving on to the moderate fracture risk category. This is a patient, again, who has not had hip or spine fractures, but her bone mineral density T-score is not as good as in the low fracture risk category. It's still above negative 2.5, but it's not in that above negative 1.0. But fortunately, a 10-year hip fracture risk is still below 3%, and a major osteoporotic fracture risk is still below 20%. So no fractures. Bone mineral density is not terrible, but not as good as the other one. And fortunately, the 10-year calculations still are good. This patient who fits into this category would not meet the criteria for pharmacologic treatment. And it's recommended, again, to reassess the fracture risk in 2 to 4 years. Now we're getting into the area of concern. We've got the high fracture risk category. This is a patient who has fractured the spine or hip, or let's say if the patient hasn't fractured, or the bone mineral density T-score of the hip or spine is worse than negative 2.5, below the negative 2.5. So that's the osteoporotic category cutoff threshold. Or a 10-year hip fracture risk of 3% or higher, or a 10-year major osteoporotic fracture risk of 20% or higher. So we've got a patient who may have fractured, or if hasn't fractured, the bone mineral density is a concern, whether it's the T-score or the 10-year calculated fracture risk. For this patient, it is recommended to have pharmacologic treatment because we really want to She's high risk. We want to prevent fractures, or if she has fracture, prevent another one. And again, she may not have a fracture, but looking at the T-score, looking at the 10-year calculated risk, it's or if she meets any of these, she's in the high risk category and should be on medication. So what medication would that be for high risk fracture patients? Well, one more thing, the recent fracture is the highest risk. It's sort of like secondary prevention with coronary artery disease. If you've had an event, let's say a myocardial infarction, you're at high risk to develop a future one and definitely want to be on treatment. So prescribing most commonly bisphosphonates, which include alendronate, risedronate, those are oral, or the zoledronic acid intravenous, or abandronate. I just mentioned, consider the pre-treatment dental evaluation. It's rare that patients have osteonecrosis of the jaw, but just sort of gestalt, if you have a patient who hasn't been to a dentist in a long time or there's issues, it's like, have her go to the dentist, and say to her, be good to go there soon and get checked out, make sure there's nothing major going on. And then let's get you started on medicine, because if there needs to be significant dental work, that's when usually you hold off on the bisphosphonates. Abandronate, which has the good news of being administered just once a month, is not recommended because as of yet, and it's been out for years, there's no evidence that it decreases non-vertebral or hip fractures. So the others are considered more efficacious. And after 5 years of alendronate, which was in the study, the oral bisphosphonate, you could decrease the dose by 1/2. So instead of giving 70 milligrams once a week, you could give it 70 milligrams every 2 weeks, and you can maintain the efficacy. And that was the FLEX study. If you have a real motivated and highly medication adherent patient, that would be an option. But the reason that I'm hesitant is if you have a 70 milligrams every 2 weeks, it's kind of easy to forget a dose. Was this the week you take the medicine, or was this the week you don't take it? As opposed to 70 milligrams once a week, it's like, okay, every Wednesday, that's the day to take the medication. So it's just helpful from a practical purpose. Okay, there was the low, the moderate, the high, and now the very high fracture risk category. Multiple spine fractures. So not maybe a fracture, but definitely a fracture, but 2 or more. And the bone mineral density T-score being of the hip or spine being below or worse than -2.5. Pharmacologic treatment is not only indicated, but to consider an anabolic medication rather than just the anti-resorptive of, let's say, the bisphosphonates. Now, what's challenging in the field in our country and globally is we've got the tools to assess fracture risk. We have the medications available to reduce the risk. So as opposed to previously where we weren't sure how to screen patients and the medicines really weren't proven to be good, those days are gone. Things work well. Despite that, most patients at high fracture risk are not on treatment. So it's considered specifically with our aging population, it's a worldwide crisis in osteoporotic care. Most of the people who need it aren't getting it. So if we can all just increase our awareness and be ready to help patients for what really is a significant medical problem. So back to our case. So we've recognized that she has significant disease. We want her to be on pharmacologic therapy. When do we reassess her fracture risk? And do you continue the medication once you reassess it? Well, in terms of continuing bisphosphonate, it's recommended to reassess the fracture risk after 3 years of the intravenous bisphosphonate, zoledronic acid, or 5 years for the oral, such as alendronate. So we're giving her state-of-the-art medicine, but we want to make sure that things are going well. If patients stay at high risk, then continue the treatment. And the medicines have been given many years. but at 3 to 5 years, depending on if it's intravenous or oral, to check. So continue the treatment, or at that point, maybe consider an anabolic treatment. If the patient improves and goes from high risk to low to moderate fracture risk, then consider a bisphosphonate holiday, holding the treatment up to 5 years or longer, depending on how the assessment's going with the bone mineral density and clinical circumstances, such as if she fractured. If she fractured off the medicine, then you want to intensify treatment and to get her back on therapy. And restart treatment if there's been a significant bone mineral density decrease, a new fracture, or other clinical risk factors. Let's say, for whatever reason, she has to go on glucocorticoids at relatively high dose daily, then you're talking about a different clinical scenario. That's just a picture of Shenandoah National Park. It's just so beautiful. Okay, back to drug holiday. Might a drug holiday be indicated? Well, again, if you have an oral bisphosphonate, you're usually giving it for 5 years. In this patient who's on the oral bisphosphonate, if she's had no history of fracture and her T-score improves to greater than negative 2.5, she'd be a candidate for considering a drug holiday for 2 to 4 years if she's been on alendronate, or just for 6 months of sidronate. But alendronate's been around longer and has its advantages with this. Then drug holiday is a possibility. But if she fractures, or she has a T-score that's worse than negative 2.5, no drug holiday is recommended. Consider treatment for up to 10 years. And in a few years, there'll be even more data in terms of patients who have been on longer than 10 years. But certainly there's a lot of data on patients who've been on the medication for up to 10 years. Excuse me. Now, if you have the intravenous form of bisphosphonate with a zoledronic acid, it's usually given every year for 3 years. And if there's no existing vertebral fracture and the femoral neck T-score is better than negative 2.5, consider a subsequent drug holiday for 3 years, but again, reassess. But if there's high-risk fractures, let's say she's had existing vertebral fractures, where the T-score of the femoral neck is worse than negative 2.5, keep with the yearly treatment beyond 3 years while watching for potential adverse events. Okay, denosumab. Shifting gears here. We went over the anti-resorptive bisphosphonates, now the anti-resorptive denosumab, which is a monoclonal antibody. So it's an alternative. Bisphosphonates are still typically the treatment of choice for high fracture risk, but an alternative would be denosumab. The best candidates for this would be older patients. So let's say you have a 90-year-old who you need to treat. This may be the one. Patients who are intolerant of other treatments, including the intravenous bisphosphonate, or if you have markedly impaired renal function, where bisphosphonates are not recommended, you could go ahead and give denosumab at that point. This is one you want to correct any hypocalcemia and or vitamin D deficiency before starting. And you certainly want the patients to be on calcium and vitamin D anyhow, but particularly with denosumab before embarking on that treatment. And again, there's the possibility of the rare osteonecrosis of the jaw, so dental evaluation is recommended. It's good to have anyhow, but particularly when starting these medications. And there's no dosage adjustment needed in chronic renal failure, but if the creatinine clearance is under 30, it'd be good to work with the patient's renal team, because osteoporosis can be difficult to distinguish from the chronic kidney disease associated mineral and bone disorders. But there's caveats to denosumab. And one is the off-ramp. And you probably have read some things that there's concerns about stopping the medicine. So with the stop issues, prior to treatment, before you prescribe the first denosumab dose, patient education should be that denosumab starts a lifelong osteoporosis treatment. Just to really make sure she understands it's not a medicine to have one or a couple of doses and just stop and get lost to follow-up, because that would be a potential concern. And discontinuing after 6 months of whatever your last dose leads to a complete and rapid reversal of its effects on bone turnover markers and bone densities. And it looks like the fracture protection is gone. So while on treatment, things look good. Patient significantly lowers her risk for fracture. Stopping it and not going to anything else greatly wanes in terms of protection. And so treatment interruption and drug holiday is not advised. These are not the patients you consider drug holidays for. And teriparatide, which is one of the anabolic agents, is actually less effective after denosumab than before denosumab is given. So it's not ineffective, but less effective. So there are options after 5 or 10 years of denosumab. One is assess the fracture risk. You're going to do the bone mineral density as well as the clinical evaluation, making sure there's been no new fractures. If the patient stays at high risk, continue denosumab, which is the best option. And again, for older patients, that may be the only treatment they ever need for bone mineral density issues. Or you can substitute another medicine. But again, you've got to, for her sake, give her something, give her some pharmacologic agent, because otherwise she's going to lose the benefit she gained while on treatment. So sequence matters. Post-denosumab medication options may not work as well. We already talked about the anabolic agent teriparatide. But bisphosphonates you can start 6 months. So denosumab's classically given subcutaneously every 6 months. So when it's time to give a denosumab, and for whatever reason, if you're going to switch, start the bisphosphonate 6 months after the last treatment. The IV hasn't as well determined as PO, but if you're going to give IV, go right ahead and do it 6 months after. And then she's on treatment that should help her maintain her bone mass. But then once the patient's on bisphosphonates, then you follow the bisphosphonate protocol, and then you could consider a drug holiday. So if it's patient who's been on oral lendronate, let's say, after 5 years, assess, or if it's IV zoledronic acid after 3 years, assess. Anabolic, we talked about, there's teriparatide, which you give for 2 years, and that's a parathyroid hormone agent, or abaloparatide, which is a parathyroid hormone-related protein agent for 2 years, or romosozumab, which you would give for 1 year, and that's one of the monoclonal antibodies. So these are bone builders, anabolic agents, but you can't keep on them, and that's why they have this time limitation. And the bone mineral density gains during treatment are lost in the months after discontinuation. So again, you don't want to have them just finish the medicine, get lost to follow-up, because they're going to lose the benefits. So you want to start an anti-resorptive agent, typically bisphosphonate or denosumab, at the time of the anabolic withdrawal. So it's sort of like passing the baton at that point. Okay, case number 2. 65-year-old East Asian female. So she's getting into the older range, although as time goes on, I always look at 65 now as kind of young. East Asian, we've seen patients who are ethnic Japanese, Chinese, Korean. We know they have an increased risk of osteoporosis compared to other ethnic groups. And female, again, she's postmenopausal. She's had several past vertebral fractures. So right away, we're concerned. It wouldn't be a surprise if she had a new fracture at some point. And now, oh my gosh, she's got the hip fracture, which again has such significant health concerns with this. And her bone mineral density, T-score, no surprise. Her spine is negative 3.0, and her hip is negative 3.5, so below that negative 2.5 threshold for osteoporosis. And no surprise, her FRAX score risk in the next 10 years of major osteoporotic fracture would be 22%, and hip fracture 5%. So the age, the ethnicity, the gender, the past fractures, including a hip fracture, low T-scores, high FRAX scores. So with her, what are the non-pharmacologic measures? Always important to consider beyond uh, pharmacologic. We'd like people not to smoke. We'd like people not to drink to excess, to exercise, to take precautions. What is the prescribed medication? And at that point, we've done diligence. We're going to put her on a treatment. And for her, because of her multiple fractures, she's in the very high fracture risk category. And so consider a parathyroid or parathyroid-related protein analog treatment, teriparatide or the abaloparatide, for 2 years, or the romosozumab for 1 year, because she's got significant bone disease. And if we could do something aggressive to lower the risk of fracture, she would be the perfect candidate for that. And then after the drug use, give an anti-resorptive treatment such as oral bisphosphonate. So you've done diligence. You've identified the problem. You've done the exact right things in characterizing it. You've got your prescription pathway ready to give her something. But she declines a bisphosphonate because she's worried about potential side effects. And she declines injectables because of the inconvenience. So what do you do now? Well, fortunately, for whatever reason, if you don't give an anti-resorptive or anabolics, there are options. You can do the selective estrogen receptor modulators, raloxifene, tamoxifen. These are particularly helpful if she's at high risk for breast cancer, but you do need to make sure the patient doesn't have significant risk for venothromboembolic disease, because then this category would not be good. There's menopausal hormone therapy, and you would give estrogen and progestin if the patient has an intact uterus, or if she's undergone hysterectomy, just estrogen. And that does protect bones. And for many years, postmenopausal estrogens were given at large numbers for many years. And the pendulum swung to the point where it was greatly reduced in the number of prescriptions. And the pendulum sort of swinging back where you would evaluate patients, because certain patients are very good candidates for menopausal treatment for a period of time. But we know that menopausal treatment with gonadal hormones, estrogen, a variety of kinds, does help protect bones. But you want to avoid it if there's past coronary artery disease, cerebrovascular disease, or breast cancer. There's calcitonin, and that's really the last prescription medicine, only if the patient cannot tolerate any of the other drugs. It helps some, but not a lot, and there's unknown long-term cancer risk. But in the meantime, you want to do the calcium supplementation, vitamin D supplementation, lifestyle changes. So this is a graph. It shows a variety of therapies, and it shows it lowers the relative risk of vertebral fracture, non-vertebral fracture, hip fracture. So interventional pharmacologic therapy does help. And in terms of preferences, if you look sort of down the cascade, you're looking at efficacy, you're looking at adverse effects predominantly at the beginning. Then you start to look at convenience of administration, oral versus injectable. Some patients like the injectable because it's once a year and like you're done until next year. In terms of dosing frequency, for some patients, injectable is not acceptable. And then important cost issues, duration of treatment, how long the drug's been on the market. Many of these have been on many years, but obviously some have been longer than others. So there's some practical issues. And in terms of cost, this was a couple of years ago. I'm not aware of a since then when I tried to look it up, but I think they're similar. But again, it shows you the difference. Alendronate generic oral, under $500 a couple of years ago. Per year. Zoledronic acid, a little more, but that doesn't take into account the injection clinic fees. Denosumab, you're starting to get a big hike, and then the anabolics, teriparatide, very expensive, but may be covered on whatever insurance if you have a patient who is just failing the others. Well-tolerated meds, but there's possible side effects. So with the bisphosphonates, gastrointestinal, so with the upper GI, if you have a patient, esophageal, in fact, recently in MAVEN Project, there was a consult for a patient who was osteoporotic, needed to be on medicine, but she had Barrett's esophagus, so she's not a candidate for oral bisphosphonate. But if you use intravenous, you're bypassing the gastrointestinal tract. Hypocalcemia, you would like to correct before, and rare, keyword rare, occurrences of jaw osteonecrosis and atypical femoral fractures. If you look at risk, benefits, considering how many women have osteoporosis, how many percentage of those very high, unfortunately, suffer a fracture, and the sequelae of a fracture, there's a morbidity associated with it. With patients, a lot of them don't go back to as independent living as they did before, and there's a mortality to it. So osteoporosis meds rarely cause significant problems. They do. It's important to know. But untreated patients are much more likely to be at risk. Denosumab, hypocalcemia, even more important, make sure it's corrected before hypophosphatemia, and rare, same thing, jaw osteonecrosis and atypical femoral fractures. Teriparatide, transient hypercalcemia has really not been much of an issue. Excuse me, and rare osteosarcoma that really the medicines have been around for years, and there's no groundswell of, oh my gosh, we're seeing problems. It's more in labs, animal studies, but something to just keep in mind. So this is a busy slide, and Dr. Einstein will make sure you get the slide set. So don't worry about taking notes with this, but it helps to give you a pathway. You've got the postmenopausal women, lifestyle, nutritional optimization, the calcium, vitamin D supplements. You want to know the 10-year fracture risk. You're going to do the bone mineral density using the country-specific guidelines for ethnicity. If they're low to moderate fracture risk, you're going to reassess it in 2 to 4 years. If they're high or very high fracture risk, you've got the bisphosphonates. You can give orally or intravenously with calcium and vitamin D. You're going to reassess them in 3 to 5 years, depending on the route of administration. If they stay high risk, continue therapy or go to another one. If it's low risk, then, you know, the possibility of a drug holiday, but keep reassessing. And if it's a patient who, for whatever reason, is intolerant to that, there's other options. If you have vasomotor symptoms, then that would be a good candidate for hormone therapy, barring contraindication. No vasomotor symptoms, but high fracture risk, you've got the SERMs. And again, if you've got a patient who you need to treat, there is options. There's SERM and going down, as we mentioned. If you have a patient with denosumab, you're going to reassess, but if you're going to continue therapy, again, that's the main thing. Don't stop and do nothing. Continue some sort of therapy. If not denosumab, then going to something like the bisphosphonate. And the same thing if you have very high risk and you go with the anabolics, you're going to do 2 years, the calcium, vitamin D, go to another form of treatment, and just to help keep her protected. So the key messages to patients: fractures are serious and they impact health as well as survival. They're not just painful and inconvenient. They really have significant sequelae. There are serious side effects from medications, but fortunately, they're very rare. Drug summaries and package inserts list all side effects, but they don't state how rare they are. For each potential, here's one example, atypical femoral fracture, there are 50 osteoporotic fractures that could have been prevented. So that's a very conservative estimate. It could very well be a different number. And the probability of jaw osteonecrosis, 0.001%, and that's the same percentage for the probability of atypical femur fractures. So whereas 10 million Americans over the age of 50 have osteoporosis, and there's 2 million fractures yearly due to osteoporosis. So we're talking really common versus quite rare. And it's a chronic disease, just like diabetes and hypertension. And we can effectively treat it and reduce the fracture risk. We don't cure it, but it is lifelong attention, whether they're on meds or being monitored. So the take-home points: treat the high-risk patients, especially if there's a past fracture. With bisphosphonates or denosumab, they should be the first treatment choices if there's a high fracture risk, and reassess the fracture risk after bisphosphonate treatment of 3 years if it's intravenous or 5 years oral. Consider a drug holiday for bisphosphonates if there's a low to moderate fracture risk, but no drug holiday for denosumab. You want to continue it or switch to another medicine, and prescribe anabolic treatment if there's very high fracture risks, such as multiple fractures, and supplement calcium and vitamin D in diet or with over-the-counter treatment in all patients. Most of them are going to need over-the-counter supplementation. So in summary, postmenopausal osteoporosis treatment starts with non-pharmacologic treatment. Remember the patients who are visually impaired or hearing issues or balance or muscle weakness. Drug treatment is often needed. Risk stratification helps all of us point to which drug for how long and when to reassess, and drug holiday and off-ramp considerations. And if the drug of choice is not appropriate, then there are alternative medicines. Here are the resources, the Endocrine Society guidelines. You can look